understand that technology is good for business and growth. But in the same survey, 2/3 said, we don't believe, we have no reasonable assurance that technology is good for people and planet. So then two things can be true. One is technology is not good, or more likely technology is good, but it is being very, very badly sold because people like us, only 1 in 3, really understand that it can be positive. So what's the answer? The answer is to make innovation more ethical and more transparent. So ethical means, firstly, data has to be sold not as a precious thing that I only give away if it is protected, but as the new blood, which it is a duty to share if I can help to save lives. And I think this individualistic hesitation about data technology is perhaps more widespread in the Cartesian West, but it is a world problem. So that would be the first part of ethics. The second part of ethics is inclusion yes, stigma no. We have to design our digital innovation pathways to fight against the stigma that we find in our society, whatever it is, HIV, hepatitis, health. And the third element of ethics is fighting for true science. And that doesn't mean necessarily modern science, Western science, randomized controlled trials. The non-rational and the rational come together, but the fake news has to be pushed out. So much for ethics. The transparency, I would say, let the citizens into the lab. Send the screen to the patient. This is a big deal. 10 years as a Royal College of Physicians, e-health in London, trying to get people to screen to the patient. Most British resident health professionals how terrible is that. Thirdly, and this is a challenge in the world of AI, make technology intelligible. Ideas, can we do it? And keep the human in the loop. And let that slow things down. So there are some real tensions. And finally, I think the answer to what Dr. Sarah Karagudu was saying, the challenge to AI and the issue around both medicine. In Europe, we do patient-reported outcome measures. So he mentioned feedback. The difference between feedback and measurement is the formalization of some of the statistics that emerge from the feedback data. I personally, not being a statistician, believe that dirty data, if it's passed, is good. So I would favour knowing that the toilet is unclean rather than waiting until over a week, 90% say unclean. So data has to be appropriate to the issue. But I think making the patient not just central, not just humanistically engaged, but using what the patient says to measure the validity of the procedure is going to be very good. And last but not least, I only say a few words on this because we're coming back to it in much detail later, government and governance. As a public servant in Europe, a lot of people in government say governance is the enemy of government. I'm an elected, or I'm an appointed administrator. Governance is the cream on the top, the sauce underneath. Personally, I think the two things go together. There is no efficient government without legitimate government. And if we are not sufficiently, if we're not seen by public opinion to be sufficiently open, transparent, and participative, then we bump up against what political scientists would call the limits of representative democracy. So, like everybody in this room, I have been proud to serve and to live as a citizen of a representative democracy. But is that the answer? Is that a panacea? No, we still have to intentionally craft the way in which we make policy. And I think the vision that I have found helpful in the cultures I have worked in is to say, you are a stakeholder. If you answer yes to one of two questions, A, do you claim to pursue the same goal as the administration? B, do you claim that the administration in pursuing its goal will affect what you are doing? If you say yes to either of those, come into the room. This is a dangerously open, some would say, but it actually avoids questions about, do I respect what you're doing, do I like the type of business card? It allows knowledge to come in. And in a structured dialogue, owned by trustable organizations, bad ideas are crowded out. And I think that moving from an untrusting world where we say, if you don't have the right hat, to a world where we say, come in, let's test your ideas, is the single central thought. The second thought is to be very clear, what can the nation do and what should the local do? And I think at the national level, in a period of big capital change, there is a lot that's needed at the national level. You need a vision, you need benchmarking, you need research, you need planning, and you need a structure for peer-to-peer learning and to take a good idea here and share it over further. Workforce planning, procurement standards, interoperability, data protection, some data tools. All of this can be efficiently shared, though not created or specified at the level of the nation. And that does not diminish the scope for very, very local public-private partnerships, which I would argue should be not only for big hospitals, but also for public health centres and for over-the-counter type digital gadgets. So what to do very broadly, therefore, bring in broad structured dialogue, launch those platforms, link them downwards as well as upwards, then it will be a success. Next week in the European Parliament, we are launching a European conversation which is open to the world about AI for people. How do we take the promises of artificial intelligence, including in the health sphere, and make sure that they are safe and deterministic? Big challenge. Our American friends with private money have been researching a lot in this area for a couple of years. This is the first endeavour at continental level in Europe. There has been some movement in France with President Macron. There's been a new council announced in London but not yet established. I would say, come join in. Let's have the voice of India also in a debate like that. And there we will build a future together. Nobody knows the answers to these questions. But let me close by saying, I don't like being so much talk about participating in this exchange. Because the mere fact of convening a meeting like this is a success factor for digital talent in this country, and hopefully then you will be able to share your learnings with others and help the rest of the world as well. Thank you very much.
I think I must congratulate Dr. to compress so much of wisdom, experience, and just pour it out and let it flow so smoothly and so lucidly. And I'd just like to say that, a public health probably resonates with our ancient culture. Our Vedas, just a little excerpt, it says, Sarve Sattu Niramaya, Sarve Bhadrani Pachantu, Ma Kaschit Dubhag Bhave. Let there be light for everybody. Let there be happiness for everybody. And oh Lord, keep everybody healthy. That is the kind of culture we as a society or a civilization come from. And I guess this is exactly what we're talking here. Few salient points which I'm going to take home after Mr. Mathin's lecture are holistic health, keeping the humans in the loop. That was a punchline for me. That was actually a punchline for me, that we should not let the emotions move away. Data protection. As we're moving towards digitalization, data is something which can be stolen, which can be misused. So how do we evolve systems and methodologies to save that data, keep our patients' rights and responsibilities there? Adaptability. No idea should be lost. I actually relate with it. I've been tinkering with a lot of ideas over myself and my organization. They just go back into a diary because somebody says, oh, we can do it better. And the biggest punchline he said was the teamwork. As one health professional, I cannot fix it. It's the team which has to do the delivery system, the policy makers, the people who understand it better than me. It's like an organization. You get the best people to do the job that they're supposed to do the job. So I'll just ask Dr. Khushi Patel to come and tell us their talk. Right on the stage, Mr. Ayn Aveku from Ministry of Social Affairs Estonia for the European Union of countries. He's a panelist here. Helen Roslo, ex-advisor, Ministry of Health, South Africa. Mr. Atul Jain, General Secretary, Deen Dayal Institute of India. This session is going to be very interesting. We are going to be talking about country perspectives. There are some people who actually transform the way public health is administered, delivered, analyzed, accumulated. So we learn from their experiences. And I again, sitting here a little on one out with take down notes for my organization and try to put it into the again, a small little thing which I learned was just an anecdote. 7 years ago, I was operating my aunt and my mother's younger sister, and they were both sitting together. So my mom just went to the washroom, and by the time she came back, her sister was sitting back in the same chair. And her sister said, "Oh, you went to the washroom? I got operated." And my mom said, "Wow, that fast." So in the evening when we were having coffee together, 7 years ago, 8 years ago, my mom said, "The way you guys are going with technology, computers and lasers, very soon you'll be seeing patients from a mobile phone." And that gave me an idea. And that's what started taking me into imaging systems and mobile phones, smartphones, and I'm sure there's some fantastic innovators here. Anand is here, who are doing that kind of thing. So that this technology has the potential to transform the way we see patients, we give them healthcare, and preventive healthcare. Preventive healthcare, I guess, as Dr. Madeline said, return of investment. If you educate people, if you spread information about disease prevention, you save so much of money which you would have spent curing the patient. Thank you. Having said that, I will invite Mr. Ayn. He has actually, I've been reading about that, he's used some proven innovations in his country, Estonia, which has transformed the way medical information, data analysis, and how you better utilization of facilities in a country with smaller economic reserve. Dr. Ayn.
Coming from a country which is 1,000 times smaller than India. 1.3 million people. But it is not just smart, but it really is also great respect. I'm sharing with you my personal view, but also some of the experience that Estonia has been able to go through. My personal this will be pleasant and desirable. We transform healthcare and we can hopefully save the healthcare as well. So, Estonia as a country will just in 1 week time celebrate 100 years of existence. So I will express with you as myself that we history of managing our country, there was a corruption between 25 years ago, pretty much at the same time when the internet was born. We started to be built. And somewhere in the end of last century, birth of this century, our Prime Minister at that time had a vision that he wanted his department and also the government to talk to citizens in an efficient way. In a way that not each of them can develop their own information processing system, information technology available already at that time. So he said, I want my government and my department to talk to each other without and well, they did. People working for him started with solutions. Then they invited a lot of companies, foreign international companies there, which had already solutions already. And they offered all the solutions that the company normally had 2 zeros too much. So, but the Prime Minister was stubborn. He said, I still want it. So he turned to his local engineer. Estonia has had engineering tradition also decades ago. The first public health institution working with data acquired in 1976 permission at that time as Moscow to have the most powerful computer in the Soviet Union. That was processes health data. And but long story short, those engineers offered a solution around 2001, which was capable of securely exchanging data between different departments, but what was most important, also private sector was involved in building and using the same solution. The first solution that the government built for that was filing the taxes. So currently in Estonia, it takes about 15 minutes, 15 minutes, to look what the government has about you, about taxation, about all your employers, you have a mortgage from the bank, account that data comes, if you release that, usually because it's much more convenient in the state of the government. Then it takes 3 more days to rebate to the government. So building these kind of value-added services is what government started with, and that is why people started prosecuting those services. At the same time, private sector developed internet banking on top of the same infrastructure. Utility companies offer ways to engage with them. So altogether by today, 1,500 public services are available. In fact, the number is growing rapidly. There was agreement to don't show the slides. I will show you the slide of this. This is a graph of new services that still every day people are inventing. There was mentioning, Robert, that we need innovation to unleash, giving this opportunity to the public sector and the private sector unleash that innovation. So for e-health, currently in Estonia, all citizens, remember there was just 1.3 million, but all of them do have access to their health data. The same data that all their GPs, family doctors can share with their hospitals, vice versa. 99% of e-prescriptions are digital. So again, if I need it, I could call my doctor from here. She could write me a prescription. And maybe there will be one time that I could buy this prescription here in India. I could do that in Estonia, in any pharmacy. And in June, the sale will be possible from Finland to Estonia. So the world is coming together with a digital tool. We have also personalized medicine program since 2002. So 5% of adult population in Estonia have donated their blood and have also allowed the genomic information to be extracted from that and linked with all possible health data for the research purposes. And now the number will be grown with the support of the government this year to 150,000, which is then about 15% of the population. They trust this service. Now, the trust didn't come to Estonia by chance, didn't land there 17 years ago. When Genome Foundation started and asked people, would you be willing to donate your blood so that we can combine all your health data, give it to the researchers who will work with that in de-identified, anonymized form, and if we find some useful solutions, then we will give back to the health system so that personalized solutions could be offered to you. 18%, 1/8 of Estonians said, I think this is nice. Last year, the survey, the support rate was 70%. So again, starting from this taxation, then providing digital subscription, talking to your teacher at school, engaging with your children in that form, or your local municipality, or your social care provider. All that is resting on this trust, which has grown over time. Now I come to very important point, how this trust among other things has been created. Yes, it was initiated by the state, but it is open and transparent. So I can see all data processing that has been done with my data by any agency. With my doctor, my family doctor checks the medical file that I, a day or two ago, had while I was in the hospital. I can see that. And that applies not only to healthcare, but all other sectors as well. So effectively what that does mean is that every Estonian is, in a good way, policing over all other data groups. There is patient portal, I can go and see what has been done with my data. Also, from my own mobile phone, I can give access to that medical information to the doctor that I trust, or not allow, in certain cases, certain information to be seen. I have the power to control the data. I have the transparency. So this is what, in a way, has given this feeling that even though, in most cases, the default condition is that doctors will change my data, because I assume that is the moral obligation for my doctor to work with all the data that's available in order to make a decision. But I always have this control over when and why that takes place. And also, what it does eventually is that it prevents systematic misuse. Yes, we have had doctors, we have had nurses, we have had police officers who have watched the data of any certain individual when they were not entitled to do so. They got caught, they lose their jobs and their licenses. And by today, most people, most professionals understand that they operate in the room where nothing can go unnoticed. Whereas if somebody looks at my paper file, I would never know what they will do. So it will not kind of create this trust out of nothing. It just adds this another layer of transparency, which helps them, if used prudently, to increase trust and build those services. And I would like to finish with why I feel that this might be something that is useful for this great country. That when last year in the second half of Estonia held European EU presidency, this peculiar way that each European member state chairs all the policy meetings in Europe every 6 months' time. So this is how we keep that Estonia is equal to Germany. And indeed, over those 6 months period, yes, the Germans listened to Estonia, French listened to Estonia, as all others. And the story that started to resonate back is that perhaps not the technology, not that Estonians do something, but the way you have been able to engage your citizens is something that we could learn from and then build our own governance, our own technology, and our own legal framework around that, how this will be implemented in any country. And in addition to those policy discussions, we also discovered with our team, working with the ministry, that it won't be enough if only policy mechanisms things about themselves. So we created something which was digital health society, which is when different stakeholders, academia, industry partners, also government members, start working together in solving some specific problems. And to cut it short, there were 4 task forces created. I'm very happy that Angela and Helmut are part of one of those task forces, one of the 2 that are my favorite. One is about interoperability, so I'm a little bit tech guy as well, but another one is citizens and data cooperation. So how to make practical ways to implement best practice solutions, how citizens can control the data, create this playing field where different providers can work for them, where researchers can work with them and find ways how to use that data for academic and new discoveries, and then create a learning health system which quickly feeds back to this new knowledge to the everyday provision. So I would like to finish with findings that I discovered, and that started to listen back from many countries that I had a chance to talk about these things over the last year, is that those societies who are willing and capable to move forward, because they have the trust by their people, can do so. And with that, once again, thank you very much for this opportunity. I'm looking forward to future opportunities to work.
I think it was a very, very pleasant, short, crisp. It was like a left undercut job. The few things that really stood out for me was he said, Mr. Hines said, trusting of services. I guess that's a big punchline. People will not let you share the data. People will not let you into their lives. Even your friend will not share deepest secrets if he doesn't trust you. Even your spouse. So trust comes first. And how a country like Estonia, and by the way, India is also listening now. You said Germany listened to you, India is listening. So a country like Estonia has transformed people's trust, and the way people have agreed to share the data for the benefit of the society on the whole, the country as a whole, is amazing. And I think maybe there's a lesson for us in this part of the world, is to be more trusting towards our government, what our government does for us, what the governance policies. A beautiful example which I see is, what if, I'm just throwing a question here to this audience and people here, what if data sharing was rewarded in some way for the person who agrees to share the data? What a wonderful idea it would be. Maybe get some benefits in its healthcare, some kind of research which comes, he can get some free access to that research. How about making money on the data? You see that on YouTube. My son makes YouTubes on circuit building, and he gets the remuneration by the ads clear. A person like me, I record my surgical videos, it gets me viewership. Rewards may not be monetary. It may be monetary. For a country like India, to start, to kickstart, it could be a good idea. If you need to share your data with relevant parties with complete confidentiality and complete assurance of security that's not going to leak, how about people who agree to sign up get some kind of a reward? That reward can be defined as per se. I think that's a wonderful concept which we in this part of the world can work. Another beautiful thing you said, that digitalization needs to be pleasant. A very, very powerful and a very profound statement. The experience of digital use, digital efficacy and delivery has to be pleasant also. So I guess that's how you people have been able to achieve what you have. An amazing learning, and I think that's what the purpose of this gathering is. It's a dialogue. It's not a speech, it's not a lecture, it's a dialogue. So it's a two-way session. So now I'll invite Ms. Helen Rosdorf, who's the next advisor, Ministry of Health, South Africa, Biomed Helix, South Africa. And I believe she's an advisor to the Ministry of Health, South Africa. where she has pioneered the concept of public-private partnership forums in health and as a means to deliver healthcare in rough terrains of South Africa using very frugal innovations. And though I believe she has training in healthcare communication. Dr. Helen.
Thank you very much for the opportunity. It's a huge honor for me to be here. I live and work in Cape Town. Most of my life, I've been able to travel a little, but it's my first visit to India, and I thank you for the opportunity and the honor. A little bit about myself. I was an advisor to Western Cape Minister of Health for 7 or 8 years. And when leaving government, I am now in a situation where I am consulting to the first cooperative bank for the health sector in South Africa. I'm also the director of the Medics, which works with new innovations, in particular HIV. And I head a foundation in South Africa, working directly with the Department of Health, addressing the matter of waiting lists for surgery. So the reason why I'm telling you this is because I feel that I stand with my one foot in public health, and I stand with my other foot in the NGO sector and in the private sector. So I see from different perspectives. I would like to start to just tell you something about the health infrastructure in South Africa and maybe some of the challenges we face. So South Africa has 9 provinces. Each province has a different cycle of people, to put it that way. And every province has a city or an urban area, and then most of our people are split into rural areas, and we have 11 different languages. So you can imagine the kind of challenge that poses to a public health system. The other challenge is that we have a huge immigration of people from all over Africa into South Africa. 20% of our patients are not from South Africa. So that means that we are working with databases of people not only in South Africa, but all over Africa, also talking different languages. The next thing to understand is the situation with broadband, internet, and mobile. So the research has shown that South Africa comes first in Africa when it comes to the availability of broadband. But when it comes to mobile, that is where we are really the most affordable country in Africa. That means that most of our patients communicate with mobile, not with internet. People in small rural villages, with no network coverage for them, but they can still communicate with the internet. So, that is to give you a little bit of the background of the challenges we face. So what I would like to do now is to also explain to you the situation with our doctors and staffing, which is a huge challenge. We have one doctor in South Africa for every 1,000 patients. We have a huge shortage of nurses. Our qualified nurses tend to travel to other countries for better money, better experience. So this matter of how we distribute the available capacity of qualified doctors and nurses is such a perfect scenario to bring in. So quite appropriately, 2018 January, the National Department of Health of South Africa launched the Digital Health Insurance Plan, and every province also launched a provincial plan for health. There's a competition of the 10 best innovators of every province will be appointed this year, and obviously then there will be a list of finalists. But this is not what it's about. It shows the trend of digitalization and how very important this digital health subject is. So, the theme of going digital is also in South Africa a developing theme. It is not something that is now at the end of its life. I would like to use, and this will be the last part of what I would like to talk about, because I think this is something that we really have to discuss and in the audience. But I would like to tell you a little about an app that was launched in 2012 in South Africa. It was called Mom Connect. So the then Minister of Health, Dr. Aaron Motsoaledi, was faced with this challenge in 2012 that we had 35% and we had to find a way to raise that number in a very short time. So they brought together the private sector, they brought together government, they brought different departments together and put it on the table, and with funding from the private sector, they started the Mom Connect. They started with 500,000 pregnant women. So how it works is you are pregnant, you get into the system, and the communication starts. This is where you are in your pregnancy, this is the signs you have. If you're not following these guidelines, report to your clinic as soon as possible. Today, 6 years later, there's 2 million mothers on that database. And the benefit of that is that the babies that are born are also become part of that database and that system and grows from. So I would like to use that as a success story in a country which I think might have some similarities with India in some of the challenges we face, which I referred to in the past. So, in closing, I like the theme of trust. I think this is one problem that was showed up in South Africa in our research, is that, strangely enough, it was not the mothers that distrusted the system. It was the health practitioners that distrusted the system. And that was in the monitoring and evaluation reports afterwards, that was what came back, is that the target audience was really the health practitioners to convince them to use it. And so I think the theme of trust is something that we can put as a thread. Thank you very much for the opportunity.
I would say that I'm sure a lot of people here from India resonate with the idea. Poverty, illiteracy, lack of trust. We're not talking about big cities here. We're talking about second-tier, third-tier cities, maybe rural areas. Mistrust is bound to happen because of maybe our social belief systems, taboos. The awareness about our diseases is bound to be one big stumbling block, but how they've overcome that is phenomenal. One great idea is you enrolled a mother in 2012 and it's 2017. So if there are 2 million mothers, you probably have another 2 to 3 million children who've joined this data bank. So you have 5 million people. So I guess, and the way they say in our country now, there are a lot of movies, social relevant movies, they say you empower a woman, you empower a family, you empower a family, you empower a society, you empower a society, you empower a nation. So the way these people have gone about, empowering women to take care of their own maternal health, making sure about healthy deliveries, having healthy babies, lowering the infant mortality, and it is bound to spread over. So this is again, I guess, a classical example about smartphones, about how these apps are going to transform the way public health is administered, public health data is saved, acquired. I myself am working on some apps like that for in my particular super specialty of eye care, preventive eye care. The potential is huge, not just for money, for patient outreach, but the social benefits. Uh, if I talk about my particular specialty, the preventable blindness, there's a huge, huge backlog in my country. And if you're just able to tap to the right people at the right time, give them information about the disease, let them know when they need to see a doctor and when not unnecessarily visit a doctor for small illness, it is transforming the way the practice is done. So there's so many lessons to be learned, and now I welcome Sri Atul Jain, who I'm sure will give you the perspective of our country. He's the General Secretary of Deen Dayal Research Institute and over 2 decades work experience in the social sector. And he's presently working in Chitrakoot, where they've transformed 500 villages. And I just as an footnote, I'll say Chitrakoot is also transforming the way eye care is delivered in this country. Thank you.
Namaskar and very good afternoon to everybody here. My institute's name has been mentioned twice before by Dr. Vinay Sespudechi, and the organizers say so there must be some kind of curiosity. What exactly is Deen Dayal Research Institute? So briefly, Deen Dayal Research Institute was set up by Nanaji Deshmukh in 1968 in the memory of Pandit Deen Dayal Upadhyay. And Pandit Deen Dayal Upadhyay was a great statesman of this country who gave us a philosophy, a very Indian, truly Indian philosophy, which he titled as Integral Humanism. And he died in his early years in 1968. Nanaji was a contemporary of Pandit Deen Dayal Upadhyay. They had worked together. He was a colleague. So he thought in his memory, and to translate this philosophy into action, he created this. He founded this institute in 1968. So first, we were just working on the intellectual level, and Nanaji was propagating various aspects of this philosophy. But in 1978 onwards, he took to rural development and set up an institute, a branch of it in Gonda district in eastern UP. Thereafter, we went to Maharashtra, in another backward district of Maharashtra. And finally, the flagship program of ours started in Chitrakoot, where we are working in over 500 villages. And there we are working to achieve 5 zeros. 5 zeros is zero poverty, zero illiteracy, zero disease, and zero conflict also. Zero conflict means zero dispute among the villagers. There shouldn't be any kind of dispute among themselves. There shouldn't be any conflict among themselves, so that they can progress well in a harmonious atmosphere. What Nanaji started in 1978, what he perceived was that there has to be a holistic approach towards the development of the society. And it was, as I said, it was a translation of integral humanism that Pandit Deen Dayal Upadhyay had propagated in early 60s. And it's a coincidence that this year we are celebrating the birth centenaries of Buddha, great personalities. And another interesting aspect is that this philosophy of integral humanism is governing this country right now. The central government, the union government in 18 states are working on this philosophy of integral humanism. Briefly, this integral humanism, exactly what it is. So it's just an essence of the Indian lifestyle, of the Indian culture, of its social, economic, and other aspects, its cultural aspects. And a very important part of this philosophy is a balanced, healthy approach towards body, mind, and soul. This is now, I'm coming to the subject of today's sessions. And in 1978 itself, when digitalization was not often heard in this country, Nanaji, maybe a little later, not exactly in 1978, but a little later, he was the person who introduced these things. He said that we must take to digitalization, we should adopt the modern systems of technology, because there were two particular words which Deendayalji and Nanaji both dwelt upon. One was Deshanukul, that is anchored to the roots of the country. You are rooted in your country's demands and needs and various aspects. And the other was Yuganukul. That means you have to be in tune with the current times. So every aspect of that was taken into consideration while he was evolving a model for development of the rural India. Health was a very important aspect. As I said, among the 5 zeros was, 1 zero was zero disease. So how to achieve that zero? That was very important to understand. He said that we just cannot go along and tell people that if you have got some problem, go to the doctor. He instead said that let us work on the preventive care systems, not the curative ones. And how can it be achieved? It cannot just be achieved by medical sciences. That comes later on. It has to be through the holistic approach towards the life. And when we say the holistic approach, it has to be in consonance with our ecology, with our native lifestyle, with the biodiversity that persists in that particular area, and other natural resources that are available, including the quality of soil, the availability of water, what kind of water is available, what kind of climate is available. So he said that we, and some of you will please excuse me for saying it, that we don't believe in the Western maxim which says an apple a day keeps the doctor away. An apple a day cannot keep the doctor away in Chitrakoot because there is no apple there. The apple from the nearest point has to come from over 1500 to 2000 kilometers, and when it reaches, by the time it loses its production or it's coming from the cold storage, it has lost its sheen and it has lost its nutritional values also. So he said, why don't you have a guava? Because it is grown in a tree in your backyard. So let's have it. And by the time we had started working there, our volunteers were there, they were confronted with the problem that there was a lot of deforestation. There were not many trees, guava, or even the local berries had disappeared. So Deendayal Research Institute volunteers said, first we should attempt to grow these trees and the local trees, local fruits, local vegetables, local crops, local grains, and a mixture of these. If this is ensured, then we can say we can give good nutrition to our people in that area. And if they are getting good nutrients, good nutrition, then the need for medicines comes down. Because there is an old saying here that if your diet is not correct, that medicines won't be of any use. And if your diet is correct, you don't need medicines at all. So the DRI volunteers started working on this system. And when we evolved a holistic model of development, we just did not say that it will be only the health aspect of that we are taking into consideration. It was the education part of it. It was the ecology part of it. Because all were interrelated to each other. And we worked on them simultaneously. And that's what the integral humanism approach was. So Nanaji said that when we are teaching our students about the healthcare, about the cultural aspects of it, then we should be speaking about the native things, about the local things. And it's not that we should be importing everything. Importing means not physical import, importing the thoughts. Of course, thoughts from elsewhere are also welcome. But the problem is, and I may be something little skeptical about it, particularly today's subject, that digitalization has a tendency to impose international standards to a very large extent. Digitalization is very important. And as I said, we also believe in Yuganukul Samaj, a Yuganukul society that is in tune with the current times. But digitalization of what? The content is more important than the technical aspect of it. And in his inaugural address, Dr. Vinay Sehesrabudhe had also said that more than the professional approach, we have to be more concerned about the human aspect of it. The human touch has to be given. And the human touch, when we started working in Chitrakoot, was, we found that people there in those areas, they have got so much of traditional wisdom, so much of traditional wisdom. They knew what to eat, when to eat, which part to eat, which part to be plucked in which season. But all this knowledge was lost over a period of time due to some influences of the education system that we adopted and the lifestyles which we adopted. Sometimes due to the influence of media also, and sometimes due to very large urbanization, very rapid urbanization. When people go outside from their villages, they migrate to cities, and when they come back with some new ideas and some crazy ideas times also. So they will come back from the cities, they will say ki what we are eating there is an apple. It's a very good fruit, it's very delicious. Why don't you also try? A villager would be tempted to try that. Instead of plucking a banana or a guava from there, he would go to the market, buy an apple. And nowadays, sometimes even a place like Chitrakoot apples are selling for 200 rupees a kg. And which apples are those? You know, so, Deen Dayal Research Institute has been working, has been trying to evolve a model which is based on local economy, local ecology, local wisdom. And as you said, that trust has to be there. People in those areas, particularly those areas where we are working and elsewhere also in the country, we find that they have got a lot of trust among each other. What they exactly need is some kind of platform where the digitalization of their wisdom can be put together, it can be analyzed, and it can be put to a larger interest of the society. That's all I have to say. Thank you very much.
I think Mr. Atul Jain totally veered the direction, new direction to the whole discourse. I remember as a little kid, my grandmother saying, never eat fruits which are not growing in your locality. They need to be imported from a foreign country because the nature didn't want you to eat that in that weather at that time. And I remember diarrhea, you would just eat watermelon and you'd be fine. I'd share I do a lot of public speaking. I was supposed to do a keynote address for one of my gods in ophthalmology, whose books I read. And this was a session organized by the All India Ophthalmic Society. And I was supposed to do a welcome address. And guess what? I lost my voice one evening before. I called my friend who's an ENT surgeon. I was speaking like I had a woman's voice. Something happened to my throat. So I went to him. He said, you need to take steroids. You have to speak tomorrow morning, afternoon at 2 o'clock. So he prescribed some strong steroids for me. And my mom, she said, take honey, black pepper, ginger, turmeric. Keep swallowing these spoons. And I, being a doctor, surgeon, I was wanting to avoid steroids. Believe me, in 2 hours, my throat was clear. And I started then believing in this particular medicine. It's so beautiful that living in this part of the world, I could be talking about digital information technology. I'm a trained surgeon. I train surgeons all over the world. Yet I believe in this integral humanism. Right place, right thing. You have to adopt those methods. You have to indigenize the methodology of the way we treat patients. I have so many patients who suffer from early diabetic retinopathy. In case you know what it means, I'm sure you do. I've started prescribing them pranayam. Pranayam is nothing but a breathing exercise. It just pumps enough oxygen into your system. The only problem with our style of medicine was we do not document it, we do not archive it, we do not publish it. But yet it works. So what I've started in my organization is there are a lot of patients who are taking some local remedies like eating jamuns or neems for their diabetes. And they're getting diabetic retinopathy. So I tell them, you keep doing what you're doing because I don't want to suppress this, as you said. When you say Western or modern, sometimes you seem dominant. And when you appear as dominant to the other person, the listening for you stops. It happens. You can talk to your son, you dominate, he stops listening to you. You talk to your wife, at least, of course, all wives, all husbands. The moment it appears that you're dominating or imposing your perception that I am right, I know more, the listening stops. If the listening stops, adaptability finishes. So I started doing that in my clinical practice. I started telling patients, keep doing whatever you're doing, but I just need to monitor you. And then when I suggested something, they were more amenable to what I was saying because I took what they were saying, I accepted. So they accepted my change of their lifestyle, my recommendations. So I guess this is a large humanitarian or integral humanism concept, which I think it's present all over the world. Local systems, local societies, local way of living. That we can adapt the systems to the way we live, the way we survive. And bottom line was, what I heard was zero dispute. Amazing how you can achieve zero dispute amongst villages, human beings in toto, but in case you are, it reminds me of that 6 Sigma. We do these quality assurance programs in my organization, and the trainer always says 6 Sigma. And that's so unachievable, that 6 Sigma of perfection, but I believe your organization has done that. Congratulations. Now I'd just like to invite Dr. Vinod Gautam to come and felicitate Mr. Ain Avikshu. Am I right? Yeah. Professor Mohammed Akhtar. Ms. Helen Rosso. And Dr. Rakshit Garg to felicitate Mr. Atul Jain. And now I guess we open the session for some question answers if there are any from the audience.
Yeah, I want to say something. Good afternoon. My name is Dr. Ashar. Sorry, my voice is broken, like you said. I also have a problem. So, actually, I was listening to the speakers, and one important thought came to my mind, that why don't we empower traditional caregivers and privilege them to treat patients in rural areas in the Indian context and support them through a network of telemedicine where a modern practitioners is readily available to them to actually help them take care of patients there. That is one observation I made. Second is regarding funding in rural areas in India. Obviously, we are a developing country with scarcity of funds, especially in rendering care to rural areas. So, how can human capital play a role in actually financing healthcare? By human capital, I mean a patient living in rural areas may not be able to pay money for his care, but he would be able to pay through kind or labor. Like Sir talked about blood transfusion, donating blood or something, or maybe helping a hospital being built through labor, or helping some kind of, helping in kind to actually fund for his healthcare. And the last observation I want to give is, obviously there is a vision at the top level to actually have a better healthcare in society. But, there should be a system from working ground up, giving ownership, to the people who are at the grassroots level, maybe those self-help groups, which can help to disseminate knowledge, bring about behavioral change, and also a monitoring system for evaluating these behavioral change and care at the ground level. So these were some observations I wanted to make. I think the speakers would like to comment on that.
One particular aspect I can comment on. Yeah, am I audible? You said something about the traditional medicines being given to traditional treatment, given to villagers through telemedicines. In fact, instead of telemedicines, what we are working among them is, among the villagers, is that our volunteers train the villagers themselves on certain aspects of local medicines. We have devised one Dadi Maka Batua that is based on it's a kit, kind of kit based on the home remedies that our grandmas used to practice. And we have identified 32 such herbs which are given in a kit to every village. In one village, kind of Vaidya, who is not, we'll say, that, qualified Vaidya as such, but he is given some kind of training, very short training, and some reorientation courses are also done regularly. They are taught into preventive care through these 32 hubs. So what they have been doing is that they have been going to, our volunteers have been going to villages every week, every fortnight, and replenish their stocks. Whenever they need some kind of medicine, if they tell us that this particular herb is now running short of supply, then we supply them these herbs, which are free of cost. The society pays for it. Society means it comes through donations that we take from different people and then give, buy the herbs. And what we do is that we try to grow those herbs also there locally, because they are climatically suited to those particular atmosphere. And I think the medical fraternity will agree with me that if some local things are given, they suit the DNA of that particular area. So they are genetically also they are more effective. What we have seen in those villages that these 32 herbs really do wonders many a time, and not many people will go to the doctors. Recently, last week only, it was in 11th and 12th, we had organized 108 camps of doctors from across the country. They had come there to Chitrakoot. They stayed among the villagers for a night, for a day. They were there. They wanted to offer their services free of cost, and they were with their kids, etc. But what we found that villagers were more interested in traditional kind of treatment. When I said that 100 doctors, they all were allopathic doctors, MBBS, MDs, and super specialty doctors also were there. They had offered their services, and we had organized all these things in 108 villages in those areas where we are working. Still, people preferred Ayurvedic rather the local herbs, and they said कि डॉक्टर साहब हम लोगों को तो उसी से फायदा होता है, आप हमको ये दूसरी अंग्रेजी दवाइयां मत दीजिए. That was the common reference there. Most of the people believed in that.
Two questions rather. So you said that people, because I also belong to Bhimtal, and I feel that more and more people these days are not trusting the local medicines. But you say that in your area is the local medicines. Is it because you're promoting it, or is it a natural thing in the people? My second question is, like you said, that you're working on 5 zeros, and I was keen to know what has been the impact of the 5 zeros and how much have you achieved?
The impact of 5 zeros.
One of the adjacent questions, that is why I'm sorry to interrupt you. Again, also this 5 zeros, I am interested more in the tension-free society, creating a tension-free society.
We'll chat about that later.
After the 40 years of your ruling on the SHG, where you've been able to make it, confidently can you say that you have achieved better result in this? And if result is positive, yes. What was the method you used and what were indicators you used for measuring these kind of examples?
I won't go into the details of those methods, but I can say something about the impact of it. In 2006, when Dr. Kalam was the president of India, he had visited Chandrapur. And by that time, we had achieved these 5 zeros in 80 of the 500 villages where we were working. So at that time, Nanaji was alive. And Dr. Kalam asked Nanaji, what is the target for achieving these 5 zeros in all the 500 villages? Nanaji told him that it is 2012. He said, no, can you advance the target? Can you do it by 2010? And when you really achieve it, I will come here. And may not be that I am president by that time, but I will definitely come, and I will inquire from other sources also, particularly from the government sources, whether your claims are true or not. So in 2010, our volunteers said, okay, they went with a renewed enthusiasm and zeal, and they went to the villages. The government of Madhya Pradesh, the district administration, etc., they said, and they told the president at that time, by that time Dr. Kalam was in president, told Dr. Kalam that they have